Okay, hi. Thank you very much, Dr. Masaki, for that kind introduction. So as you can see from this first slide, I'm the chief of rheumatology, and a lot of people ask me what that means. It doesn't mean the person who assigns rooms in the hospital. Rheumatology comes from that same stem as rheumatism, which some of you may understand and recognize, has to do with aches and pains in your joints and muscles. So rheumatologists take care of people who have aches and pains all over, anywhere, one place, many places. And sometimes those aches and pains are associated with what we call systemic diseases, and diseases you may have heard of like lupus, and things as obscure as even things like syphilis can cause aches and pains. We're not going to talk about any of that today. We're going to talk about gout, which is a real serious pain. James Gilray, I think, did a great explanation of what gout looks like. I don't have to say any more to describe it. If any of you have ever had gout, this is what it feels like. It's a devil biting at your joint. It's very, very, very painful. So painful that you don't even want to breathe on it, much less put a sheet on top of it. So we'll talk today about what gout is, who can get it, what are the underlying causes, what are the consequences of having gout, and what can someone with gout do to reduce episodes of gout? Are there controversies related to gout and or uric acid elevations? And what is pseudogout, and how is it different from gout? So we'll talk about it. First, I want to start with what gout is. It's very common. It's the second most common joint problem. The first is what we refer to as osteoarthritis or degenerative joint disease. And it can be an acute event in a single joint. It can happen once. It may not happen again for 10 years. It can happen once and then start increasing the frequency to once, twice a year, 3 times a year, 6 times a year, 12 times a year, or more. It can also be a chronic damaging arthritis that can deform your joints. Some people don't recognize that. They only think of gout as an acute, recurrent, single joint arthritis. It's characterized, and this is the way rheumatologists make the diagnosis when you walk in the office and say, oh, I was fine, and then I woke up suddenly with a pain, swelling, redness, and tenderness at one or more joints, usually just one the first time. Most often, the first time, which is 60% of the time, at the base of the great toe, one toe. We don't know why that has a propensity, but it does. After the first attack, the second attack could be anywhere in the body, but frequently it's in the forefoot or the knee or the wrist or any other joint that you have. And it occurs suddenly and often waking the sufferer in the middle of the night. And the sensation is that like the area is on fire. The affected joint is hot, swollen, so tender, as I said, the weight of the bed sheet might be intolerable, much less a blanket. It doesn't usually cause joint damage, however, which is good to know. That first attack just feels like it is, but it's not doing any damage to the joint. And it's self-limited, and the issue for the physician is if you've never had gout before, and if that first joint happens to be in a joint that maybe you stubbed your toe, or maybe you have a cut on your toe or your foot, it could be an infection in the joint. It's hard to tell the difference. The rheumatologists sometimes have ideas, but sometimes we have to get a specimen of fluid to make sure what's going on. So this particular person has redness at that base of the great toe. It's a fiery red, sometimes almost purplish red. It's so intense. And he also has problems over his ankle. I don't know if this is his first or not. This is a filed copy. But if a person has 2 joints at one time, we call it polyarticular gout. Otherwise, we just call it gout. When gout tends to be polyarticular, it tends to be worse. Oops, sorry. Okay. So what is gout? Gout is caused by crystals of uric acid that precipitate inside synovial fluid. And your body doesn't like it there, so it creates this inflammatory response to try to get rid of the crystals. But you know what? The crystals are so sharp that they break up the cells, and the cells spill out all this stuff that's supposed to be things to digest the crystals, but instead it causes intense inflammation. And if you don't do anything about gout, it usually goes away in 3 to 10 days by itself. Even if you just suffer with the pain, it usually doesn't cause any damage. And it will go away without treatment, but you probably feel better if you had the treatment because many people can't even walk if it's on their foot. So as I said, 60% of the first attacks occur in the big toe, which means that 40% are somewhere else. After the first attack, sometimes you can't predict where the next one will be. Some people only have it in their great toe, but everything that hurts the great toe is not gout, and gout will not always hurt the big toe. So that's something to remember. Now, after the first attack, the second one might take 10 years to occur, or it might be the next month or sooner. And it's not predictable, and there's no way that your rheumatologist or your primary care physician would know when your next attack will be. Gout symptoms come and go, but there are ways of managing both the symptoms and to prevent the flares, which is good. And for a rheumatologist, it's so encouraging that we can actually treat this. I can treat this much better than I can things like osteoarthritis. I can prevent pain with the treatments, it's a nice, successful thing to do. So let me talk about uric acid. Uric acid is part of your metabolic normal breakdown of both turnover of body's tissues and some foods that you eat. Uric acid is dissolved in the blood, and to a level of 6.9 milligrams per milliliter, it's fine. Higher levels are supersaturated, and those crystals will form, particularly in areas, and we think maybe the great toe is because it's cooler, maybe the circulation isn't as good because it's far from your heart. We don't really know why, but it does cause crystals in body fluids, and those crystals sometimes stay in the fluids, but sometimes they're in the tissues also. So when they collect in tissues, these painless lumps are called tophi. And this picture on the right shows a hand that has all these painless lumps in it. It could be misinterpreted as osteoarthritis, but osteoarthritis doesn't give you these white lumps. Sometimes they leak, and they leak out, and the patients will tell me, oh, it's like toothpaste that came out of that lump. I don't know why that is, and that's probably uric acid crystals, rarely anything else. Tophi could overlie damaged bones or joints, and they could occur even if there's no gout attack at that site. I've had patients who've presented to me with having gout, no gout, but have tophi. So that's really interesting. So in the looking up what tissues are breaking down, I came across this really nice website. If you ever want to see it, it's called bionumbers.org. And it tells you all sorts of biological data. And this one was how quickly various cells and various tissues turn over, just to know where this uric acid is coming from. So your small intestine epithelial cells turn over every 2 to 4 days. What happens to the old cells? Well, they get broken down by your body in the normal processes, and guess what? Uric acid is formed. So these are all the tissues that break down. And many of them, it's just a few days, and some much longer. So you go all the way down this list. Your red blood cells turn over every 4 months. So something has to happen to the old cells when they turn over, and that can form uric acid. So these are all the various things. Some cells we think last a lifetime, which is the cells in the lens of your eye, and the ova in the female ovary can last a lifetime. Central nervous system, that's interesting because we think your nerve cells last a lifetime, but we're finding out that they can be replaced. So this is old data, but it's very interesting to see it. Anyway, I thought in preparing for this talk, you should see that even I can learn, which is important. I don't know anything. I can learn a lot. So what is uric acid? So uric acid can, when it's in the blood and it's being excreted in the kidneys, can cause kidney stones. And some people know that they have uric acid kidney stones. There's interesting that humans make uric acid, then it has to be excreted. Most other animals can digest it with something called uricase, an enzyme that exists that humans do not have, that changes uric acid into another chemical that's very soluble and can be excreted, but not humans and some higher primates. Other mammals and birds do not build up uric acid at all. Dalmatians are special. They can build up uric acid in the blood. They never get gout, but they get serious kidney disease from it. So I thought that was really interesting. They have a different reason why their uric acid builds up than humans do. They have uricase, but there's another genetic defect. So what causes the increased uric acid, as I remember? Most times with people with gout, they're not excreting it well. Their body turns over the uric acid, and instead of putting it out in the urine, like most people do, 90%, 85 to 90% have a problem, and it's because of the genetic control of the transporters across the kidney membranes. It turns out that 2/3 of the uric acid that you produce every day, and we all do, is excreted by the kidney, and 1/3 is excreted by the cells in the intestines by the same mechanisms, okay, which is something that's very interesting. Certain medications decrease the ability for you to eliminate uric acid, and some of those are very common. I'll show you some lists later. And some increase it by causing turnover. And some interfere with the kidney's ability to eliminate uric acid. So there are lots of reasons, but if you noticed, let me see the next slide. Less commonly, just overproduction increases tissue breakdown. And that happens in certain cancers when the chemotherapy is given. Sometimes they have to give something to reduce uric acid because that could cause a lot of problems immediately. Rapid turnover of cells in certain kinds of skin diseases, particularly psoriasis, can also increase uric acid in the body. But this is important. Only about 5% of the body's uric acid comes from your diet, unless the only thing you eat is beef liver and beef kidney. Then there's a lot of uric acid production because of the breakdown of those tissues. But I don't know anybody who eats only exclusively that. Diet, however, can affect the frequency of attacks because it can change the levels of uric acid in your body sort of acutely, and that might precipitate gout attacks. So if you or someone you know has gout and they say, you know, every single time I go to a party and eat a lot of meat products, I get gout the next day. As a rheumatologist, in the week after Super Bowl, I see more people have attacks of gout because they overeat and they overdrink, particularly things like beer. Super Bowl parties. What do you do in those Super Bowl parties? So if you ate only carrots and drank water, you probably would not have a gout attack. So just remember that next time you have a Super Bowl party and you have gout. It won't cause gout if you don't have it, if you don't have a propensity to get it, if your uric acid levels are not a little bit higher at that borderline. Most people don't have high uric acid, so it won't happen to just anybody. So some causes of decreased uric clearance, and this is mostly in the kidneys, but sometimes we think this may also affect the clearance of the bowels, and that's alcohol, particularly beer, not as much from wine. Diuretics or water pills, they interfere with the ability for your kidneys to push that uric acid out. Certain low doses of salicylates. Salicylates is like aspirin. And I remember when, I've been around long enough, that taking low dose of aspirin to prevent heart disease was being promoted. And I said, oh no, all these patients are going to have uric acid elevation because low doses can increase the uric acid. It turns out the low doses that we use for heart disease prevention are probably not enough to make a big difference. So the other thing that'll happen in very, very high doses of aspirin, which we're not using anymore, we used to use this for rheumatoid arthritis, uric acids were terribly low. They were not terrible, I'm not meaning terrible in a bad way, but they were very, very low. They're 2 to 4 milligrams % or lower, which is well below the 6.9, which is the solubility level. And that's because we gave lots of aspirin, up to 10 grams a day, okay? And that reduced uric acid because it promoted the excretion. So these other drugs, which are not drugs that you commonly use, these are TB drugs. Certain laxatives that cause your blood to become more alkalotic can do it. Levodopa is a drug that many people are on and can cause decreased excretion. And these are other drugs that most people are not taking, but they can increase the uric acid level in the blood by reducing the amount that is excreted in the kidney. So who gets gout? You know, these are a lot of people. David didn't get gout, but Michelangelo apparently suffered from gout. So Thomas Jefferson, Isaac Newton, Alfred Lord Tennyson, and probably other very common people, but they just didn't get their names in the books. But according to some history books, these people all had episodes where they suffered from gout. You notice that not all of them are massively overweight, some are, and overweight does correlate with the occurrence of gout. So we live in Hawaii, and a lot of our colleagues and a lot of our patients come from the Pacific Rim. And Pacific Rim people who are Maori, Samoan, Guamanian, Native Hawaiian, some Alaskan natives, have a greater tendency to have gout because they have more frequency of certain genetic interference with the excretion of uric acid. So the other thing that's happening is gout is increasing worldwide. There are people who say the reason for that is obesity is increasing worldwide. And there is a connection between obesity, something called metabolic syndrome, which includes diabetes, high blood pressure, and obesity and heart disease, is also correlated with having gout and high uric acid levels. So this is a demonstration of where gout is most prevalent. The dark blue is the highest prevalence. Oops, that's the United States, okay, and Spain, and East Asia. A little bit less prominent in Canada and Australia. And these beige areas, we don't have the data, so I can't tell you what it is. Apparently, according to the statistics, it's very uncommon in Russia. And it's less common in Norway than it is in Sweden, which to me doesn't make very much sense, but it may be the way that's been counted. And unfortunately, Finland doesn't have any data. So you can see, this came out of an article I found fairly recently, so it's pretty much up to date. The problem is people are not tracking gout as much as they should. Oh, who cares? It's only gout. You know, it's not going to kill you. It's going to cause you disability, but people don't look at that statistically as much as they could. But anyway, there is clearly an increase, and why the United States is greater than others, I'm not sure. So, also, this is the occurrence of gout with age. So you can see the 18 to 25-year-olds is this first place, and then up to 29-year-olds. And as we get older, and over the 60s, you can start seeing that gout increases in frequency and prevalence. So this is the USA line. The green line, which is kind of following the yellow line, is both Sweden and Australia. Portugal is dark blue, and South Korea is the lowest, which is interesting because it's a Pacific Rim nation too, but it has a lot of Asian influence. So who knows? We're looking at the genetics, not me, but there are people looking at this to see if there's some clue that we can help fix for some of the people. But the U.S. is up there. But the U.S. is also up there in obesity, so that might be part of it. And is obesity less in Australia, Sweden, and Portugal? Probably not. So we're not sure how these correlations occur. But I just thought these graphs were interesting, and you might have some questions about it that I probably can't answer, but I'll be glad to try. So what complications can you get from gout? So recurrent gout could give you joint damage. Medications can prevent gout attacks in people with recurrent gout. If left untreated, sometimes these erosions or eating away of the tissues of the bones can lead to bone deformities and permanent damage with destruction of a joint. So many people have many attacks of gout, and there's nothing that we can see on X-ray. We can sometimes see these concretions that I called tophus before, or tophi for the plural, that are located right next to a bone, and the bone has a hole in it. It's not really good. Now, whether or not the patient has had a gout attack, that tells me that this bone is being damaged, and I want to get that uric acid low enough so that those erosions can heal in. Advanced gout, which is untreated, and it causes deposits of uric acid into these things called tophi. It can develop in several areas, in your hands, your feet, elbows, Achilles tendons, not even a joint. Achilles tendons is a tendon. You can find these lumps of uric acid. May not cause pain, but the lumps are there, and that is a sign that your body is overloaded in uric acid. Tophi usually aren't painful, but can be. They can become inflamed. They can be infected if they get irritated, and they can drain. If they drain uric acid fluid, there's a hole in the skin, and sometimes that can lead to an infection. Kidney stones are different mechanism. Is someone who's got a very high uric acid level and is excreting all that uric acid can go into the kidney fluid and kind of get into a stone because there's just too much of it, and it creates a concretion. And anyone who's had kidney stones thinks that's probably pretty bad. You don't want to have that happen. So anyone with that capability, we have them drink lots of fluids to make sure there's a good flow of urine going through to try to prevent it, but at the same time try to prevent the increase in the uric acid in the blood. So the pearls of wisdom. And I teach this to the students as well as residents and to primary care physicians. Sometimes they don't hear it. Although 60% of the first attacks are on the first metatarsophalangeal joint, that's that base of the big toe, 40% are elsewhere, and it could be anywhere. 15% of the first attacks are more than one joint at a time or polyarticular, multiple joints. 25% of patients have normal serum uric acid during the attack, but if you measure it when they're not having an attack, it may be elevated. It should be elevated. So frequently I have a patient come to see me. I went to the ER, he went to the ER with a hot swollen joint someplace, and they checked my blood level and they said, I don't have gout. I don't know what to make with that. I want to see their blood levels when they're not having an attack to know whether gout is involved. I wish I had a specimen of fluid, and I'll show you that in a little bit, why I could see gout there. So 20% of patients who have a history of gout will have an acute attack during hospitalization for something else. So one of the things I used to be called for was a patient had, let's say, hip replacement surgery. And 3 days later, his knee was swollen and hot, and his white blood cell count in his blood was elevated, and he had a fever. And the question was, does he have an infection in his knee, or does he have a gout attack? If it's an infection, it must be treated right away. It could damage the hip that was just replaced. It could damage his knee. It could kill the patient. So it's really important to make that differential and not assume it's gout. However, if the patient says, you know, this is just like the gout attacks I've always have, usually they're right. And so that's part of the history that we take. If it's exactly the same, then that's a good sign that it's probably gout. And at that point, we frequently will just take a sample of this fluid from the joint. If it's the knee, it's a lot easier to take, and look at it under the microscope. You could show gout and you could show infection together. So it's a difficult differential to make. When I say differential, to make the right diagnosis, that they will call a rheumatologist and an infectious disease expert to decide what the next step should be. So sometimes you can see these tophi in the ear. See this white thing? There's some over here. We have a trick. I take this patient into the exam room and I get that light that I use to look in the ear, or any other light, and look behind the ear and see if the light will go through this white thing. If it goes through it, it's probably a cyst of some sort. But if it's blocked, and all I see is a black spot, it's very likely, most likely to be some uric acid deposit. Sometimes I've taken just a little needle and just sliced a little bit and got on a slide, and I can see the uric acid crystals too. So treatment. Gout is considered a completely treatable form of arthritis. Okay? You don't have to suffer with this if you have it. Worldwide, however, only 40% of gout patients are getting adequate treatment, whether it's because they weren't given it or they're not taking it because they don't believe or they don't realize that this can be a problem for their life. Some people want to put up with the acute attacks. That's fine. If you're having one a year, that's okay. You have it. Except when you don't want to have it, you have it, and you have to get rid of it soon. I have patients whose job it is to climb ladders because they're in construction. They can't work if their foot, anywhere in their lower extremity, is involved, or their hands because they have to hold a hammer. So this could be a problem for economic reasons for patients. We should take care of it. Even though it increases with age, frequently people start having gout in their 40s or 50s, particularly men. Women may get gout, but usually it's older. After they've gone through menopause, that's when their serum uric acid seems to go up, and that they can get a gout after that. So treatment can prevent pain and suffering. It can prevent the interference with work, and also the overuse of medical services. So you don't have to go to the ER if you have a gout attack, if it's been treated or prevented, to get something for it, as long as your treating provider knows what to do. And that's where the issue is. Some people, even physicians, can be not belittle, but don't get as excited about gout as they probably should. Unfortunately, having gout may also either contribute to or It's like a marker for having other problems like cardiovascular disease, high blood pressure, and stroke. So if you have gout, make sure you get a full physical to make sure that other things are being treated if they're. The other one I left off of this is obesity. So treatments for gout, we want to lower uric acid in your blood. We want to use drugs that can do this. And these are two common drugs that we're using. One is called allopurinol. It's been around for as long as I've been a rheumatologist. Uric is a new one, more expensive, may have some heart disease problems with it, we're not sure. And we want to use drugs perhaps that increase your uric acid excretion, and there are some drugs that do that. Now this new one, pegloticase, is a uricase. If you remember I said humans don't have uricase, well they have a uricase that we can infuse. And it can really reduce uric acid in the blood severely, but it also can cause anaphylactic shock. So we are very careful and cautious about using it and how we use it. It's a really important drug in those patients who everything else is not working. We can also reduce recurrences of attacks by watching your diet. Some people believe milk reduces the attacks. And interestingly, weight reduction, done carefully and slowly, can reduce the uric acid level in your blood, also the recurrences of attacks. But that's a real hard one to get at. I know many of us have problems. We try as hard as we can, but the weight is not coming off. And the complexity of why weight is elevated in gout, or gout is elevated, or uric acid is elevated in overweight people is an interesting problem that we haven't solved. Does hyperuricemia, that means high levels of uric acid in the blood. Okay, so is hyperuricemia or elevated uric acid, is that the same as having gout? No, that's elevated uric acid. Gout is the attack of gout in your toe or in your joint is what gout refers to, is the arthritis associated with hyperuricemia. So in a number of studies to try to say, well, what about if you have a high uric acid? Does that mean you're going to get gout? Well, maybe. If your uric acid is normal, under 6, 1.1 of those, 1.1% will get gout. But if it's high, above 10 milligrams per deciliter, half of those patients will eventually have some gout. So the answer is not always. So it's almost 50% will get it. Perhaps we can prevent it in the people who have higher levels, but maybe 100% of people don't want to take the medications until they have their first attack. So that's a discussion between you and your physician if your uric acid is high. Why would you test it? Well, maybe you test it because your kidneys aren't working fully, or maybe you have gout in the family, or you're of a Pacific Rim person. So what is pseudogout? I mentioned that before. Pseudo means not genuine. So there's a kind of acute attack in the joints that looks like gout, but it's not quite gout. It's a little bit slower onset. It never gets quite as intense, and it lasts for 3 to 5 days and goes away. And there's some of the medications that we use for real gout doesn't work for pseudogout, for attacks. But it's a crystal-caused disease, but the crystal is different. It's a different kind of a crystal. This also may be associated with having chronic arthritis, and it's not uncommon to have pseudogout along with something like degenerative arthritis or osteoarthritis. There are actually 3 different patterns of pseudogout, I'll tell you the name of that in a second. And the 3 patterns are, one is pseudogout, which means it looks like gout, but it's not. Another one is pseudo-rheumatoid arthritis because it affects many joints, a lot like rheumatoid arthritis, but is not rheumatoid arthritis. And then osteoarthritis can have these same crystals, and you might say, well, it's my osteoarthritis. Well, maybe it's not. Maybe it's this pseudogout. So as I said, it's slower onset. The joint fluid will be different, and the affected joint may remain warm and swollen more chronically, longer time than an acute gout attack would. So pseudogout is caused by this kind of a crystal. It's calcium pyrophosphate, and the sometimes named calcium pyrophosphate deposition disease, or CPPD is the most commonly used abbreviation, though I've seen it listed as CPDD, but CPPD is what most people are using. Another term is chondrocalcinosis, which means calcification of the chondro. The chondro is cartilage, so it's calcification of the cartilages. The cause of pseudogout is not known. We think there's a genetic reason for the why calcium would accumulate in cartilages, and we're not sure. It may be inherited in some cases. In some cases, it may be related to concurrent diseases. And it's more common in the elderly. And I remember a study that was done in a nursing home, and it was found in 50% of the patients who, they just did x-rays of knees. 50% of the people had chondrocalcinosis, but probably maybe 20% had knee pain. So it can exist as calcium in the joint without having symptoms. The important thing is dietary calcium is not implicated unless there's something wrong with your calcium metabolism. So I jump to the end of this part of the slide. Treatment may control underlying causes, and people who have low thyroid or hyperparathyroidism, parathyroids control calcium in your system. So sometimes that can cause you to have calcium deposition. Patients with diabetes and kidney failure have a lot more chondrocalcinosis than the average other patients do. And then there's a condition which is fascinating, and I don't think I understand why this occurs. It's very rare, called hemochromatosis. Okay. Hemochromatosis is a very rare disorder of iron metabolism, and it's mostly, we think, genetic. But when iron accumulates in the body, sometimes calcium accumulates in the joints too. So if a patient comes in to see me and has a lot of chondrocalcinosis, sometimes they'll get an iron study to see if that's a problem, because overload of iron can cause liver failure and diabetes, and it's better to take care of that one, separate disease. So how we treat most patients with pseudogout is anti-inflammatory drugs. And you know NSAIDs such as naproxen, and I didn't put in the most commonly used NSAID, which is ibuprofen or Motrin, because it doesn't last in your system long enough to treat this chronically. Motrin will last in your system for 4 hours, naproxen for 12. So taking naproxen twice a day will give you anti-inflammatory treatment for the entire 24 hours. Taking 1 or 2 doses a day of ibuprofen may help acute pain, but it won't help reduce the inflammation in a long-term way. So maintaining movement in any joint, no matter what the cause is important after the inflammation subsides. You don't have to move it when you have inflammation because it's going to be too painful and you're not going to do a good job with it. So you wait until the inflammation subsides and then go back to your usual activities. In some cases, this drug called colchicine, which is used and famous for helping acute gout, also works for patients with chondrocalcinosis, and sometimes it can prevent recurrence of attacks, because pseudogout means they have pseudogout attacks. And sometimes it can be used to treat the acute attack too, but not chronic. It used to be you use colchicine to make the difference between pseudo and real gout, but that's not the way we make the difference anymore. So I want to show you how we want to make a diagnosis and see which one it is. We pull out some synovial fluid from the patient's joint, put it under a microscope with polarizing lenses. And if you cross polarizing lenses, you make the field dark, but crystals scatter polarized light. So what you see in the top black screen is where the light is being scattered by these needle-like crystals. That's what gout crystals look like. To prove it's gout, we put a red filter in between those two polarizing lenses, and it's a very special red filter that causes the crystals to change color depending on their orientation to the crystal. So when the crystal in the joint is parallel to the axis of this indicated crystal, this is the only thing that'll do that is uric acid, the only thing. And at the same time, those crystals that are perpendicular to that axis are blue, very pretty. I wish I could do this more nowadays. I can't because there are federal regulations about my being able to use this as a diagnostic tool. I have to send it to the lab. And that's how they say, if I send a specimen of synovial fluid in a patient I think has gout, they will do the same test and say, oh, we see birefringent crystals. It's called negative birefringence. That's the title. You don't have to know why. And that's what is classic for uric acid crystals. Now, on the other side, the pseudogout, I'm going to show you where these crystals are. You can barely see them. You see this little This little thing, forget about the arrows. You see this little thing? It's almost a little bluish. Okay, that's a calcium crystal. Here you can see it under regular light microscope. This is compensated, this is polarized like this one with blue, and then the red filter is put in. That's why it looks red. And what we're looking at is the parallel to the axis of the red filter. It's blue. Not fascinating. And perpendicular to the red to the filter, it's the opposite. It's yellow. So that's how we tell the difference. Okay. Now, not only calcium crystals can show up this way, so it's not absolutely clear, except for in this case, this crystal is inside a white cell who's trying to eat it up, and this is classical for pseudogout. So we can tell by joint fluid. Now, I will tell you, there's a patient who comes in, has this really hot, swollen joint, and I take out a needle, and they say, "You're going to do what?" You can put that needle in my joint. I have to anesthetize it a little bit, but it can help me do a diagnosis. But I will tell you that they're very uncomfortable with it. The idea, once it's done, it's much easier. But the idea that we're going to actually stick a needle into this very, very tender joint is scary. But it will help. This is a patient who's got tophi that are leaking. You see that white creamy stuff? And these are tophi that aren't leaking. Look how big they are. I believe this is a woman. Okay, you can get gout, and you can get tophi, and you can get hyperuricemia in women just as much as men, except the age, there's an age shift. They're older. And so if someone who has an acute arthritis who's a woman, you don't say, "Oh, it can't be gout because you're not a man." No, I'm sorry, it can be gout. By the way, today, so let me look again here. This is a normal x-ray of a normal hand. And I want to show you what it looks like on the x-ray to see some abnormals. So this is a patient with very severe gout. You can see a little hole in the bone. Let me go back to that other picture. See how nice and smooth these lines are? Okay. Anything you see, this is not a tophus. This is just a normal bone that belongs in your wrist, in your finger. It's there. It has to be there. So these are all normal joints. The spaces, and we look at this one. This is a patient who had an amputation because they had an infection in the tophus in the finger. But you can see there's a lot of destruction. Oh, what happened over here? I have no idea. This is old, but this is destructive arthritis in this patient's hand. So this is his left hand held against the screen, okay? And this one, it says right and left. And look at this one. This was not gout that took that away. That was a surgeon. But this is a very seriously involved joint and has some calcium in it. We don't see gout crystals on x-ray. We only see where they were. So this is a patient who has some calcification in part of the healing process will happen. You'll see calcium. They're very destroyed joints. And I just stuck this other one as the normals to compare to. We'll go to the next one. Okay. So this is the foot. This is a fairly normal looking foot x-ray. And since gout occurs frequently in the foot, I thought I would bring this one in to show you. The average patient does not have gout like this. If it gets to this, it can be really serious. You can't walk on this foot. Even if he's not having an acute attack, there's so much destruction and damage in the ankle, in the toes, that this patient is disabled. I had a patient that I remember seeing who came in with a foot that looked like this, and I said, "Well, when did you have your first attack of gout?" He could not tell me. He never had an acute attack of gout. Now, maybe he didn't remember, but I can't imagine not remembering an acute attack of gout, even if it was 20 years before. So rarely this can occur in patients who don't have acute attacks. So chondrocalcinosis looks totally different. This is a knee joint, and there's supposed to be pure, clear space between the two bones. It's not really a space. It's a space that cartilage exists in. And we can't see cartilage in x-rays unless there's calcium in it in chondrocalcinosis. And here is chondrocalcinosis that exists in the knee joint. I can also see it a little bit here in the wrist joint. This is supposed to be relatively clear space. So chondrocalcinosis doesn't eat away bones as much as gout does in most cases, but it can cause recurrent inflammation that can limit what it can do. Here's another blow-up picture of that calcium in the cartilage inside the knee joint. So this is the frequency of diseases that occur in gout patients: obesity, chronic kidney disease, high blood pressure, diabetes, dyslipidemia or high cholesterol and the other lipids in the body, cardiac diseases, including coronary heart disease and heart failure and atrial fibrillation, stroke, peripheral arterial disease. I don't want to scare you, so if you have gout, make sure you just get a good physical and you check with your doctor and get things done, because you have a little bit higher propensity. If all of these are well treated, your gout might get better. There's actually a couple of studies that showed if your high blood pressure was hard to control and you have high uric acid, if you can reduce the uric acid, the hypertension gets better. And they did this in mice. They took some genetically hyperuricemic mice, and they treated some with allopurinol, the drug to reduce uric acid, and their blood pressure went down. And they took away the allopurinol, and their blood pressure went up. Now, mice are not humans, but it might be something to add if you have high uric acid without gout. It might help your high blood pressure to think about the uric acid effect. It hasn't been totally proven in multiple cases, but it's an interesting thought. And why that connection is, there's a lot of theories behind it. We wish we knew. Gout is a very old disease, but we don't know as much about it, probably because it doesn't kill people. I'm sorry to say this. Diseases that kill people we know a lot more about nowadays, but we're learning about gout. So screen, go to see a physician, make sure you have a lipid test, make sure if you need to have a diabetes test, you should have one, and check for cardiovascular disease. So I don't know how many questions you have out there, but I'm willing to listen to them, and I suspect Dr. Masaki will read me some questions and I'll answer them, and if I'm not answering them well enough, get in touch with the mini medical school and I'll be glad to answer them further. So thank you very much for your attention, and I hope none of you have gout, but if you do, or if you have relatives that do, please get them treated. If their primary care doctors are not paying attention to their gout, ask if they can see a specialist in arthritis, a rheumatologist. So thank you very much. I'm glad to have been able to give you this information today.